Right. Good morning, afternoon, evening, wherever you are in the world. We're excited to be here with you all this afternoon. My name is Sarah Whetstone, and I'll be co-facilitating this workshop with Dave and Beef2, and I'll allow them to introduce themselves.
I'm Dave Marzano. I am the program director at the University of Michigan.
And I'm Beef2 Mangesha. I'm the associate residency program director at UCSF.
Great. And I am the program director at UCSF and have the privilege of working with Beef2. Today, we are going to talk about the virtual sub-internship, which, as you can imagine, was an adaptation for COVID, but we had such a positive experience and thought it would be worthwhile to share our experience with others. So as a group, we have no disclosures. We're in resident education, so obviously don't make tons of money or have.
We might be subjective to the ACGME regulations, but that's it. They don't pay us anything.
Exactly. Our objectives today are to describe at least 2 examples of a virtual visiting sub-I program, to describe benefits of such programs for both students and programs, and to brainstorm how we can incorporate such programs into Ob-Gyn departments nationally. So the overview of our workshop is that we will, hopefully I'll share our experiences with visiting sub-internship programs before the pandemic, then give sort of a brief overview of sub-internships, including virtual sub-internships from experiences in the literature. We'll share our experiences at UCSF and the University of Michigan around virtual sub-internship experiences, and then we'll brainstorm in small groups how we could potentially incorporate such experiences into our individual programs. And so with that, I'll hand it over to Dave.
All right, so this may or may not take 15 minutes because we were anticipating a larger volume when we were going to be in person, but we just wanted to start out with having you as participants share with us what your experience was with visiting rotations prior to the pandemic, starting with how they were structured and kind of figuring out how decisions were made about who got invited to participate in those, assuming that we all have some limitations on how many outside rotators we can accept, and then what are the pluses and minuses of those. So we'll open it up to the group. If you can just unmute and talk, because I think we're a small enough group to do that. And I can just start and tell you what the experience at the University of Michigan is. So we have visiting sub-internships for our MFM rotation and our Gen-Onc rotation that are kind of set. Certainly students are allowed to apply for individualized rotations, but generally those are our 2 main groups that we have. We typically get probably about 30 to 40 that come through to the department. I don't know how many at the medical school level first get filtered down to what we see. And as far as how we decide who those people are, they submit a CV, they submit an information about why they want to do the rotation here. And then we kind of look through and say, number one, is this a student who might be provided an opportunity by rotating with us that they're not getting at their home institution? What is the purpose of, are they doing an audition kind of sub-internship? Our personal thought on that at Michigan is that our sub-internships are learning experiences and they're really not designed to be an audition interview. We make it very clear to the away rotators that it's not guaranteed that you're going to get an interview. This is a separate process, so we're not guaranteeing that you're going to do an interview, and we don't interview everyone who does an away rotation here. They get screened the same way all of our other applicants get screened. And generally, we look to make sure that we're providing diversity and equity in the choices that we make. So it's not necessarily based on what their step 1 scores are, really kind of looking at what is the reason you want to do this away rotation. And I think as far as benefits and drawbacks, the benefits are, I do think it is an opportunity for students to see a different style of practice. If they at a smaller I don't know if people would consider Ann Arbor not rural. Some people like UCSF might consider Ann Arbor rural, but a big tertiary care center versus a smaller community-based practice. There are some students who also don't have the opportunity to do an MFM rotation or a GYN oncology rotation. And so I think those are definitely the benefits. The drawbacks are there's a large amount of cost that's involved for the student. Quite often these students have partners or families that they have to leave for a month at a time. And there's definitely the potential for inequity in the sense that those students who have more resources obviously have more flexibility and being able to go away and live in a different place for a month where they have to rent a place to live, they have to pay for their meals.
Thanks, Dave. Elise, I saw your hand raised.
Oh, yeah, I can just maybe offer a different perspective. I'm at UVM. We're a very small department and a very small residency. We really have very little room for visiting students because of that. So we only have an MFM AI, an ONC AI, and I think a night float AI, and those will get easily filled up. And we only take one student on each of those a month. And so those will fill up between the months of March and September, which is when, of course, everyone wants to do this type of rotation with our own students. And so it's pretty rare that we will actually see a visiting student. We might have 2 or 3 max a year. And so we have a very casual process. It's sort of a first come, first serve sort of waitlist process. And we don't link whether or not a student comes to any sort of residency cutoffs. And we also make no promises that if you come for come for a sub-I that you would, and we call them AIs, if you came for an AI that you would be guaranteed a spot. So I'm actually coming to it to your workshop from the other side of things, of like, as someone who comes from a smaller place that it is hard to travel from, particularly when you're in the path of the bomb cyclone, like how, a virtual sub-I is something that can be, could be very useful for students from UVM or even residents from UVM who, may not get to see, a real huge GYN oncology service or something like that.
Thanks for that perspective. Very interesting and different than Dave's. I would invite other people who are participating in this workshop to share their experiences with visiting sub-internships or acting internships at their institution.
Don't make us call on you. I feel like I'm doing the M3 lecture right now where everyone's cameras off and they're muted, and then we just start calling on people. I would say that I think one of the other things that when I advise students about doing away rotations at other institutions is that for those students that are strong students, and we can all argue about who those are, but we kind of know them when we see them, is it really a worthwhile adventure to do that? Because really you have a strong application and you have strong credentials going into that, and so that if you go there and you kind of screw up and that's a place you really wanted to be, you might actually hurt yourself more than you help yourself. Whereas for students who might have a particular geographic location that they need to be in, and they may not be able to catch the eye of the program director during the screening process, it sometimes is a helpful thing to go and do that, but kind of give them the information they need to really kind of knock it out of the park. Because even though we're all going to say that these aren't audition interviews, the reality is we can't take away the experiences that we have during that time, same way that we do for our own applicants from our home institutions. Dr. Hamoud likes to always say that our Michigan medicine students have the longest interview process of everyone. It's 4 years long. And so, the interview day is less important sometimes for those students because we have a whole body of knowledge with them.
Hi, Dave.
Hey, how are
This
you?
is good. This is Renata. I was just going to add that for us, we had decided to not host students during close to those interview months because that also got very awkward if you had a student on rotation and they didn't seem to be a strong enough applicant to actually invite. And now there's just awkwardness between all parties. So we actually ended up closing our electives those months. And it's still, to speak to what you said about, sometimes the rotation can hurt you. It's that's happened too, where then they don't get an invitation, and it leaves everybody in a strange place.
It's a very uncomfortable, awkward as a program director when you have. I love the idea of closing off the rotations during that time because as a program director, particularly this last cycle, there was a student who was rotating with us during the SOAP guidelines where we sent out our invitations, and they didn't get an interview. And the residents were like, "Oh my gosh, her interview didn't go out. She must not have gotten it." I was like, "No." She didn't go out, and it made me kind of uncomfortable because I also had to go and clinically be active too, and trying to kind of wear two hats makes it uncomfortable. I totally agree. I love the idea of closing them off during that time.
Thanks, Renata, for sharing. Does anyone else want to share or is in the position to share? If not, we're happy to move on and won't torture people by calling on you. All right, we'll move on, but please know that we welcome all conversation and experiences. We think that this workshop will be enriched by your thoughts. And so I'll hand this over to Dr. Mengesha to lead sort of this discussion around sub-internships.
Thanks, Sarah, and thanks to everyone for being here. We've already kind of covered and heard some of these benefits to visiting sub-internships, but just to kind of set the foundation, they can really play an important role in teaching foundational knowledge to help prepare students for residency, and also, can serve a role of a sort of extended audition to help facilitate matching. And we know that from studies over, about 50% of students in one study had done an away rotation. And so we know that they can be common, particularly in some specialties compared to others. Some specific benefits that medical students get from doing away rotations is like what was mentioned before, getting exposure to clinical opportunities beyond what might actually be offered at their home institutions. Additionally, just getting exposure to different institutions, faculty, and programs in a direct and more longitudinal fashion, which really presents great opportunities for networking and relationship building, and hopefully leading to potentially mentorship relationships in the future. And then students also can get a little bit more of a direct, realistic look at resident life, as well as demonstrate their specific strengths beyond at their own institution. So perhaps being in a different learning setting or clinical setting that brings out those strengths, like demonstrating their adaptability and flexibility to new environments. And then for residency programs, really gaining prolonged exposure to prospective residents and getting to directly assess their skills. And then we also get an opportunity to really show the strengths of our program and have opportunities for recruitment. You can go to the next slide, Sarah. But of course, as we've heard a little bit before during our discussion, there can be some potential drawbacks to visiting sub-internships. I think one of the biggest drawbacks, as Dave mentioned earlier, is that they can be incredibly costly and time consuming in arranging logistics like transportation and housing. Students can spend anywhere from like $1,000 to $5,000 on a single away rotation. And clearly that's very limiting for those who don't have the financial resources and support to be able to do that, especially in the context of knowing they've got an expensive interview season that's coming up. And that can really bring forth a major equity issue and potentially serve to perpetuate the inequities that we see for those that are financially under-resourced and those that are that identify as underrepresented. And then, while students spend a month at an institution, it's still a short amount of time compared to the rest of their time spent in training. So you may not get a full accurate picture of their strengths and skills. And of course, one bad day or one slightly bad interaction may have a disproportionate impact on their ranking. The next slide. And so when the pandemic hit, it really proved an opportunity to reevaluate the equity and structure of our sub-internship processes as well as our interview processes, and really allowed the opportunity to kind of develop more creative solutions like virtual mentoring and online educational programs. Next slide. And so moving to virtual sub-internships still retained a lot of great opportunities and experiences for medical students in residency programs. Students still can have exposure to other sites, albeit a little obviously more limited than if they were there in person, but they still have the opportunity to see ways that other residency programs operate. They can meet and network with residents and faculty and still have the potential to create those positive mentorship relationships. And then removing the financial and logistical barriers allows for that opportunity to be extended to not just those students who are privileged enough to be able to engage in away rotations, but more broadly. And then with this format, students have even more opportunity to visit multiple programs where they can potentially do multiple of these visiting sub-internships in a similar time frame as they would for an in-person one, which allows students to kind of have more of an informed choice as they're thinking about their residency programs. And of course, some limitations is that they won't get the same clinical exposure as if they were there in person, and that might limit people's ability to be able to work towards getting a letter of recommendation if that's a goal for them during this away rotation, as they don't have kind of that consistent exposure to a single faculty member or resident during their experience. Next slide. So we just wanted to share a couple of examples of virtual sub-internships and other specialties, and then we'll talk a little bit more in detail about those that we offer at our institutions. Yale, in their plastic surgery department, had a virtual sub-internship that they published in the literature where they really immersed their students into the existing resident curriculum. And so they went to biweekly educational conferences, grand rounds, visiting professor lectureships, and had interactive resident teaching sessions. And then they also had daily faculty-led student-focused teaching, as well as a live streamed surgery component that was incorporated to help try and simulate the interactive environment in the operating room. After these experiences, they surveyed their students and found that their knowledge pre and post rotation increased over the course of the rotation. And then additionally, students felt that these experiences really had educational merit and that it was a successful way at providing a mechanism to be able to effectively recruit students and really develop an interest in the program. Next slide. And then in urology, in concert with their professional society, they created a national curriculum for programs to use, given the high rate of away rotations that their applicants did pre-pandemic. Somewhere around like 95% of those applying did at least one away rotation. And this national curriculum, which I have a little picture on this slide here on the left, sorry, it's very tiny, but it was essentially a detailed 4-week curriculum that had knowledge-based modules where they had recommended reading, links to pre-recorded lectures, links to surgical videos, simulated clinical cases, and a curated list of some seminal articles in urology. Then they also had a module that covered things like communication, feedback, handoffs, implicit bias, and professionalism. And then to try and incorporate a technical portion, they also had students create free accounts with the American College of Surgery and actually go through surgical modules with knot tying and suturing. And they found that over 3/4 of the students and program directors thought that the program was excellent or very good, and that about 45% of the students that participated and 65% of PDs did want to see this incorporated into future programming even after the pandemic was over. And so now I will turn it back over to Sarah and Dave, and we'll talk about our experiences with our virtual sub-internships at our institutions.
Great, thanks, Beef too. So, we use sub-Is in lots of different ways. We sort of use them to get to introduce students to our residency program, to also invite students who may not necessarily have considered UCSF, San Francisco as a place to train. Many students also come to UCSF to take advantage of sort of different subspecialties. We offer sub-Is in all of the subspecialties. And so we had a very robust visiting student program prior to the pandemic. It was also a very powerful recruitment tool. We had special sort of supports to ensure a diverse group of visiting students. And we were really nervous about losing that with sort of the halting of in-person sub-Is. And so we, in a very short period of time, came up with an alternative in 2020. And we had sort of three major goals. One was around exposing people to our program, really sort of using it to entice people to apply to our program. That we really wanted to create and foster relationships and connections between faculty and residents. And that we would support the trainees around application prep. I will say what frequently happened for our students is that they would come and they would spend 4 weeks with us. And sometimes it would be very positive in that we found a student who just shined in our environment and they were very strong. And other times it was that students, had a growth over the course of their sub-I, and the growth wasn't as valued as we had hoped it would be. It was almost the expectation that students would come in performing at a very high level. And so we really wanted to sort of change the sort of paradigm of our visiting program and really also spend a significant amount of time helping students prepare for, at that time, what was going to be the initial virtual cycle of applications. And the other neat thing is that it allowed us, so we created a structure that was sort of beyond one-on-one mentoring. We found that many of our UIM faculty members were feeling as if they were being asked to do a lot of work in supporting sort of our diverse sort of applicants and residents. And so instead of having a one-to-one model, we had residents and faculty, and to be honest, even fellows wanted to join. So we had either pairs or trios, and they would support 3 to 4 students at a time. And what we asked people to do didn't mean that they all had to be present all the time. And it really allowed us to broaden the reach of our residency program to underrepresented students from across the country. And in our first year, we supported 32 students virtually from 27 schools. This year, we had a very small handful of those who came in person, but then we supported another 17 students from across the country, and then also included our own medical students from UCSF in those mentoring pods to try a different way of supporting students throughout this process. And our outreach, we have residents who love social media, so they shared a lot of our posting about this opportunity on social media and to their networks. We posted it on our undergraduate medical website, and we asked people to provide a personal statement, really sort of asking sort of what their plans were for their future goals and how they plan to care for diverse populations. And we asked for their CV. Our usual process for visiting sub-Is is that we would ask for a letter of recommendation, we would ask for their transcript, and our goal was to be more inclusive and not use sort of traditional metrics in sort of choosing which students to participate in this experience. And then we had a small group of faculty who reviewed the applications. I will say we probably had close to 100 people apply for this opportunity virtually in our first cycle. And so choosing who to select was a little bit challenging. And so we had a small group that's where everyone read the applications, and then we decided together. Our program lasted for 3 months, and we were very intentional that our program ended on the day before ERAS opened. And we thought that, we wanted to support students, but that once ERAS opened, that we couldn't provide additional feedback to them in order of fairness to all applicants. And then our expectations for our mentoring pods, as we now call them, is that people have 3 to 4 meetings. The first meeting was really like a get to know you meeting, sort of, so that people would understand people's backgrounds, how they chose their specialty, how they chose the work that they do, really getting to know people to help start sort of those foundations for hopefully longer term mentoring relationships. Subsequent sessions involve personal statement and CV reviews, providing very specific feedback on ways that people could enhance both. And then, because this was our first virtual cycle, we did mock interviews with participants and were available to address individual needs and questions. So I remember with my first group, I did a practice with several of them, and one was really struggling in the virtual setting. And so we did a separate sort of practice session so that that person could really sort of feel more comfortable when interviews started. And then I had a fellow who was really interested in this idea, and this fellow emailed the students weekly over the course of those 3 months, identifying didactic opportunities. So we allowed them to participate in all sort of resident and departmental didactics as long as there wasn't protected health information. And then this fellow also graciously identified other conferences at night, during the day, that students could participate. So really sort of inviting the students to sort of see what our residents are learning. And we had a lot of really positive feedback from it. Here are some sort of examples. I'll read those out loud for people who are not able to stop and read them themselves. But even through the virtual platform, I experienced a sense of community that was unmatched, one that truly valued growth personally and professionally. You specifically detailing my experiences as a Black woman in the South, telling me to speak truth to power and pushing me to let go of my humility for at least this interview season was such profound advice for me. I held on to these words of wisdom throughout interviews. It was really nice to work closely with Dr. X, allowing me to get to learn why she does the work she does. I feel lucky. Our sessions together left me feeling like my application reflected my values and why OB-GYN is my path. And in our first cycle, almost every student applied to our program. We interviewed 14 of the 32 and ultimately matched 5. So 5 of our current interns participated in this program, and then shared that advice with many people at their schools. And so with that, I'll hand over to Dave.
Whoops, I had to talk on mute because we have to do that at least once during each Zoom session, right? So what we did was a little bit different. We did it was a day long or a half day long virtual second look that was organized by our Office of Health Equity. And this was because there were, again, this was the first year of the pandemic. I can't remember what year we're in of it now. But the first time that we went through this, and we were really struggling with ways to, in the same thing that Sarah and Bifty were talking about, is getting exposure for applicants to see, what is it like at the University of Michigan. And so kind of the rules of the road were all departments were invited to participate. All of the departments participated except for general surgery. And they ran their own separate process. And, you know, surgeons are surgeons. So we'll go with that. But both faculty and residents were invited to participate as well as all of our applicants. The way that we disseminated the information in Ob-Gyn is we utilized our fairly big social media platform. We also have several residents who are very active in social media. Our vice chair of education is very active in social media as well, but we also have a residency site that does social media. We also, as part of Ob-Gyn, we're using Thalamus, so we were able to send all of our applicants an email invitation through the Thalamus system. And then we also had our program manager send direct emails as well. And then the day of the program, again, it started at noon and it went until 5 p.m. and started with presentations by our Vice Dean of Health Equity and Inclusion, and kind of outlined you know, what it's like at the University of Michigan and what opportunities are here. And then last year's topics, that because we did it again this year, last year's topics went over institutional racism, the effects on racism on access to care, and the importance of diversity in medical education. And we had a session on LGBTQI experiences and training. Part of those topics were picked out because in review of information, that when people think of Ann Arbor, they don't necessarily think of Ann Arbor as the most diverse setting in the country to practice. And it's something that we as an Ob-Gyn program have struggled with a bit, but also our institution as well. And then the last hour of the day was the breakout sessions with the department. So applicants were able to choose whatever breakout room they wanted to go into, but the chair, the PD, and then department leaders and residents were present to have an informal discussion. And again, I think if you go to the next slide. So as an institution, we had over 350 applicants who attended the day. All the core residency programs there were except for surgery. And we had 15 applicants who joined our breakout room. And that provided a really fruitful discussion. One was for them to hear, and they asked some pretty poignant, pertinent questions about what it was like to train in Ann Arbor. We had some of both our URM faculty as well as our non-URM faculty who were there, who could speak to, you know, what it was like to be a Black woman and in Ann Arbor, Michigan, and those experiences, which I obviously can't speak to quite as well. And some of the comments that they had is that basically loved the event, especially like that there were multiple speakers who addressed different DEI issues, and that the faculty as well as the residents were present. They thought it was nice that much of the event was discussion. So it wasn't webinar format. It was this type of format so that people could raise their hands and talk and really kind of get involved with the discussion. And it wasn't just kind of people presenting their research or things that we think of as traditional lectures. And that really kind of drove home the point of diversity, equity, inclusion as an important topic at Michigan Medicine. And again, I continue to be impressed with how forward-thinking Michigan Medicine is. I believe it would thrive. I would thrive in this environment, be fortunate to train. And I think three of our students who matched this year through this process participated in that, and also had the feedback to say, and these happen to be 3 URM applicants who said, this really did help to sway me in moving you up on our rank list, because without the opportunity to visit and to see, you know, what Ann Arbor was like, and to see what the faculty, because again, on interview day, it's kind of hit or miss how many faculty participate on a certain day, and also even in getting to interact with the residents. So we did this program again this year as well. I would say it's probably a little bit, we don't have the numbers yet because it was just like a week and a half ago. We had 7 to 8 applicants in our breakout session. I think this year people are kind of a little virtually burned out is when I'm kind of guessing a bit. So we'll see if we continue with this. We will continue with it. Whether it continues, do we have to change the format to kind of fit the need? But I think, again, there's an opportunity to really showcase what our commitment was to DEI issues, but also what the interactions between faculty. So students got a chance to see faculty talking to each other, seeing the interaction between faculty and residents in the chair and in a small session, which again, was we assured them in this because it was held also after our rank list was submitted, so they could feel free to say whatever they wanted, and it was a really good discussion, and I found it to be quite enjoyable. Next slide, I think, is discussion.
Tiva, Dave, do you want to sort of explain what we want people to do?
Sure, sorry.
Yeah, go ahead.
Sorry, go ahead, Dave.
Oh, no, I was just going to say, our next step is what we'd really like to do is get input from everybody on, is there a way for us to develop blueprints and ones that will fit your institution so that, what works at UCSF and works at Michigan may not work in Vermont, or in other institutions. We were going to originally break out into small groups, but I think we're in a small group. So, I think that's kind of what we'd like to have people have a little something to take home with them from the session.
I think we might be able to still do breakout rooms with like a couple of people in each room to brainstorm for about 10 minutes or so together and individually about what your blueprint might look like. And then we'll come back after 10 minutes and share kind of what you identify. So each room has about 2 to 3 people in it. And we'll open up those breakout rooms now.
I
I wonder if you could do like in the outpatient setting, potentially have, students participating in telehealth visits and be able to proctor them virtually and take them through that. That might be one opportunity.
I think that's an awesome idea because right now with our students on my virtual days, we're not in the same physical space.
Yeah.
And so it doesn't matter whether you're in Vermont or you're in Ann Arbor, as long as I'm in Ann Arbor seeing people in Michigan, because we're not allowed to see people in different states. But I think students, there's no regulation on that. And that may be a really good idea to think about.
Yeah, I feel like you could create like a 2-week telehealth elective and your staff who are doing, your faculty who are doing telehealth, we try to have like a half morning of telehealth. The student could, go around and do different half days of telehealth with a variety of providers. That'd be a great opportunity, I think, to have them meet a bunch of faculty and sort of even see different specialties if you wanted.
And you could tailor that.
Guys. Hello, I'm sorry to interrupt you guys. I really can only listen, but I do have a question. My medical school will only give credit for any kind of like AI or pretty much anything in the clinical years if there's hands-on clinic touching the patient, managing whatever experience. And these virtual experiences are pretty much vetoed. I'm at the University of Virginia, by the way, pretty much vetoed as being able to offer credit, at least to our own students. I'm just wondering what your experiences were in your schools as to how these virtual experiences are able to offer, credits or whatever is being offered in exchange for that time. Thank you.
I think that's a great question. We were reflecting while we had sent you all off to breakout rooms, how we had sort of limited the clinical exposure because that added another layer where you would have to make sure that visiting participants, agreed to confidentiality rules, had access to your clinical electronic medical record. And so really, I think we called it a virtual sub-internship experience, but it was really centered on applicants and really centered around helping them figure out if OB-GYN was the right path and around helping them prepare their application. I think with urology, who had this sort of national effort and very much included sort of clinical and technical skills in their experience, I think you would have a greater ability to sort of offer credit. And I think because urology did it at a national level, endorsed by their like national societies, and had sort of buy-in by the vast majority of urology residency programs. I think that it was much easier for them to sort of say that the experience was more like a sub-internship than the one that we hosted at UCSF.
And obviously ours was not, it was just a half-day thing, but it's an interesting thing because our students do, as part of their rotations and as part of their sub-Is, do participate in virtual care in the same token. Like I have a student who's assigned to me, for a day a week, and on my virtual days, she actually initiates the virtual appointment and then puts the patient into a wait room. We discuss what's happened. She presents to me, and then we go back in together and see the patient, and that certainly counts towards their credit. And certainly in the height of the pandemic, there were some virtual things that students were getting credit for participating in. I don't know that it would count for a sub-I in the sense, because the concept of the sub-I is being inpatient and functioning like an intern on the floor. So I don't know that in the traditional sense of a sub-I, but I have an outpatient women's health rotation for third and fourth year medical students that isn't a sub-I, but it is something that almost all students who are going to either go into Ob-Gyn, a lot of people who are going into family medicine who want to get some extra experience with outpatient women's healthcare will rotate through. And essentially, they're functioning as if they were a resident in my clinic. They, get to go see patients, they present, and they do the virtual portions of those as well. And it might be the institutions have to maybe rethink at some of their hard rules. And I'm sure that UVA is very flexible, because all big institutions are, right? To say, the world's changing. And frankly, it's a valuable experience for students to learn how to do, because they, first of all, are much better at, when we were first all going to Zoom, they're like, oh no, here's how you put them in a waiting room. Because I was like, let's just shut the computer and everyone, we're going to go another room and talk about it for a minute, because I don't know who can hear what. But they knew how to do all that stuff, and they're actually much more adept at it than we are.
Yeah, I would just add that, yeah, I think for us, it would be elective credit. It wouldn't be something that could get advanced integration credit. I think, what this session has made me think about are there are so many opportunities to use like this new virtual platform that we have in various ways. And so just thinking out loud, we run a boot camp, a 2-week boot camp that's 4 schools. And those students from the 4 schools have to travel here to Vermont. We have to find housing for them, and there's some cost and some challenges around bringing all those students here. So thinking about making something like that virtual, using Zoom for the didactic sessions and breakout rooms for the cases, for case-based learning, and then some sort of, afternoon package that they open to do the simulations at home with a director on Zoom, or, I certainly think there are opportunities for, courses like that. Or I think about we have reading months or things for like global health that could be brought into, non-UVM students, or you could think about having learn about UVM year-long thing where they just get invites to go to the resident didactics, the fellow didactics, the grand rounds, and they have to attend, X number of hours, to get credit, so that it's a very flexible schedule, just as ways to start, making connections and showcasing all the things that are going on within your medical school, but your residencies, your fellowships, those kinds of things.
I'm kind of curious at UCSF, did you guys, did your virtual students come to like the core lectures frequently?
Yes, and many times we're very active participants.
How did your residents like that?
Well, I will say, I had a lot of residents participate in it. So, the first year when we had 32 students, I had 12 residents who were serving as mentors. So, that's almost, over a quarter of our residents. So they were engaged. They really were serving as advocates for our residents. And sometimes I thought the students participated more than the residents, but that's another discussion on virtual learning for our GME trainees. But that they were really engaged, and I think they brought an excitement. They often asked really good questions that I think sometimes lacks in virtual learning.
The reason I bring that up is that when we first went to virtual interviews, we decided to invite all of our applicants to grand rounds. And they could come to any of the grand rounds they wanted to, not necessarily the one of the interview week. And we had talked about doing it for our core lectures, and the residents are like, no, thanks. Because we like that as not as protected, so we can feel safe to make a mistake or to say something, ask that question that they may perceive as a dumb question, or something like that. So I just was curious as how well they took it. And I also agree with the virtual learning format. I'm not 100% sure how many people are actively participating in those lectures.
Yeah, I think, our residents had the same reaction. So again, I think, maybe you take a small selection so that the residents don't feel like their time has been hijacked. And then I just think about the things that we all do, and we're all recreating the wheel. Like, we all do a residences teacher's curriculum. Like, why do I have to design a residences teacher's curriculum, and Michigan and UCSF and Dartmouth? Like, we could, collaborate, and we could just have one, and we could share it amongst a bigger, group, or career advising. So similar to what you've done at UCSF. I mean, we all do the same, 8 different career advising sessions around like your CV and your ARIS application and your personal statement and your how to choose programs. And it's all this exact same curriculum. And again, we're reinventing it at each place. Like, is there an opportunity for some sort of, virtual collaboration, that we don't all have to be, doing the same thing in our own silos.
And I love that too, because it would get residents exposure to different residents and different faculty throughout the country. Our fellowships, because we have 57 different fellowships, and they have their common curriculum, but during the pandemic, they didn't know what to do. And so again, kind of started uniting and saying, what are the common topics that all the fellows need to get to, and then created virtual spaces for them. And the feedback from them has been great. And so seeing that kind of go on a national or global basis, and it really truly global in the sense that it could involve some of our global partners that don't have access to have faculty do some of the stuff that we do, could really be a beneficial thing.
Yeah. I think
so
this
like,
has,
sorry, go ahead.
I was just going to say, I think it has many layers for possibilities and expansion. I mean, I think we're all very nervous about what may happen in terms of abortion access.
Yes.
And so, especially in states that are, hostile to abortion, which also means, to abortion training for students and residents, like this could be a format where you give people lots of experiences virtually so that they get that education, they get that part of exposure to their curriculum. I think another big thing for our program is that, we have a very diverse residency program. More than half of our residents identify as underrepresented in medicine. And what's a very, very common theme for many of those students is they often felt isolated in their medical schools. They didn't have the same sort of mentorship. And so, to be honest, I've had a lot of residents really blossom in the virtual visiting sub-I, where they've taken this real leadership role in mentoring other students around applying to residency. And then once they've started, which I think is really beautiful and offers an opportunity for students to get mentorship that they may not have at their own institution.
Yeah, no, I think, we have obviously just primarily white medical school and residency and faculty here at UVM. We have a really difficult time recruiting people of color to essentially a completely white state, not only with the snow, but also the color of our skin. And so like to have that an opportunity for our students of color to have mentors, is an amazing, opportunity and way to use the platform. Yeah, I mean, I think there's just so many potential ways to sort of leverage it all.
The other opportunity that I was thinking about as we were preparing for this talk is that lends itself perfectly to this is the opportunity of a research elective, especially if you're doing data analysis from a red cap or something like that. You don't need to be physically present, but you have the opportunity to be mentored by a faculty and meet one-on-one, even some flexibility, because it doesn't have to be from 7 in the morning to 6 at night either, Monday through Friday. And I just think that, and thinking about mentorship, and I think, Dr. Erica Marsh, who does a ton of research with us, she also mentors a ton of our local students. And of course, I don't know if she loved that I'm volunteering her to mentor everyone else's students. But the thing about it is she's got, goo gobs of data to go through, and the students get great projects out of it. She does it for the residents as well, but that's something virtually that would be a great opportunity, and that would garner credit if your institutions give credit for a research elective.
I think that's such an awesome idea. And like, as we were kind of talking about people not having the resources at their home institutions to be able to do that, like having that national network where you can get those opportunities and be able to get credit, either whether it's like, on your transcript versus being able to put something on your CV that you participated in. I think that's really, really wonderful.
In some ways, I think medical education's a little bit behind because, there's these universities where you can, the one I'm thinking, it's like in Phoenix, I think it's always on the television.
TV.
Yeah. Where you can basically get any degree online and everything's online. And, we obviously, you don't want to lose the in-person piece of being a doctor, and so much that can be learned by putting your hands on a patient and really, being present in the room. But I do think, this has given us an opportunity to maybe broaden our horizons and be more creative and think outside what is our traditional box.
I was just thinking about the recent rotation we had, and I didn't, I set the student up. The student was given the schedule, and I didn't realize, because this was an RAI elective, and I wasn't as aware because their clinic schedules are on a separate system, so I can't see them. And essentially the entire rotation was virtual. It was all telehealth. And this poor student traveled here, paid to stay here, I think had use of a car, and then actually set up his lodging so he was close to the clinic where it should have been in person, but there was no space for him, so he ended up at the hospital here, had to commute to the hospital here. I was so mortified that we made this poor student travel and then go back and forth for what ended up being almost an entirely virtual rotation. When so I think these ideas, like we could do a better job of incorporating some of that. So even if it was a shortened visit, like if there's some OR time or something that the student can do in person, to have a portion of the visit in person, but for him to be here for 4 weeks and the majority of it to be telehealth, it just seemed, it just didn't seem right. When he could have stayed home and still done the telehealth portion,
And you could definitely set something up where the first 2 weeks are telehealth, the second 2 weeks you're on on the floor and in the OR, those types of things. Like, again, I think that's a great way to optimize and also reduce costs. Reduce also the the emotional burden of some of the students who are away from their families during that time is really difficult. And I think we all underestimate that. Maybe at least I should say I underestimate that. But when you sit and talk, it's like, it's really hard to eat, because we send our residents away for 1 month and it's optional for them. They don't have to do that rotation, but they have to, they're 4 hours away from Ann Arbor. And so they don't take their families with them. And they're like, this is very difficult during those times. And many of them will come back for a night for dinner. I'm like, you drove 4 hours. As a single person, I guess maybe I don't fully recognize that, but I'm like, I like dinner alone sometimes. But yeah, so yeah, I think really, the one silver lining of this whole COVID thing is it's made us all think differently, hopefully better. But
yeah, I think the hybrid opportunity too is you could potentially increase then the number of students that you could give the opportunity to, right? So like a small place like me, if you'd said you could take 2 students and one student's doing telehealth for 2 weeks while the other student's in person and then flipping. So, potentially gives you some maybe increased bandwidth to take on more students.
And definitely can see more patients. I do our residents do some virtual continuity clinics as well. As a staff, they can all be doing their virtual stuff, come in staff, and then we kind of fan out, back out. And from an access for patients who want telehealth, it also provides a great opportunity for them as well.
Yeah, and the other thing I would just say, as we've been talking about DEI here in Vermont, we are starting to use standardized patients of color because we don't have a large resource of patients here in the Vermont area of color. And so, being able to use the virtual platform to use standardized patients of color to improve the education of our students has been another great way to use the virtual platform.
Yeah, that's a great idea. I think we're at the end of our time for our sessions. We just want to thank everybody for your participation, especially on a Friday afternoon on the last day of our conference. I think this was really invigorating, certainly for me, and I think based on this discussion, probably felt that way for a lot of us here. And it's a great opportunity for us to continue to brainstorm collectively to really help create these robust, equitable, and meaningful experiences for our students.
I just want to throw a shout out to Molly and Elise for being able to put together this virtual conference at the last minute. It's been awesome. So kudos to you guys too.
Thank you. Yeah, well, it's easy when you just say, guys, come give a great workshop. So nice job. So hopefully, yeah, we should keep thinking about new ideas and some collaborations and scholarship. There's something here. I can sense it.
Definitely.
So
Thank you.
All right, everybody have a good weekend.
Stay
a
well.
lovely, yeah, stay out of the snow.
Bye.
Are you